Hello, good morning, good afternoon, good evening, and good night. So I'd like to appreciate all of you attending here. This is the this is the 11th Ifso webinar in conjunction with third APC webinar. So that this is the first time the Ifso APC work together with the Ifso webinar. So I would like to introduce my colleagues here. Please, the slide. Next slide, please. Yes, I'm Kazuka-sama from Japan. I'm now playing a role of Ifso Apc president. And our brilliant speakers, the debaters, is Dr. Rakudawara from India and Dr. Yosuke Seki from Japan. Please have some comments from both of you. First, Mufi, please.
It's great to be here, and I think it's a great topic, especially relevant for Asia, but it's great that a lot of people from all across the world have hooked into it, and I think we're going to have some fun because Seki is a very, very brilliant academician.
Thank you, Mufi. So Yosuke, please.
I'm Yosuke Seki from Japan, and it's a great honor to have a chance to talk about this very interesting topic, and I hope that everybody can enjoy. Thank you.
Okay, so that our panelists, we have three, the leading surgeon from Asian Pacific region, the one from the Korea, Professor Chen. Please have some comment.
Okay, thank you, Kaz. And I think it is a great opportunity to discuss the metabolic surgery for Asian people. I hope we will have a great lecture and we can get a great answer. Thank you. Thank you.
Thank you. And then Professor Shigen Huang from Taiwan, please.
Hello, hi everybody. Nice to meet you again. Welcome all the friends from the whole world. We look forward to this new concept of Sleep Plus. I think that would be very great fun and would be a very great debate. We can get a lot of results from this presentation. Let's see.
Thanks. And then at last, not least, the Professor Ken Loy from Australia.
Hello, everyone. Welcome. And I think I'm here to learn as well, but I hopefully can share some experience because in Australia, I think this type of surgery is not that common. And I think it's actually good to see what everyone doing in the world. I look forward for the webinar.
Thank you, Ken. And this webinar is recorded and will be uploaded in Ifso and Ifso Apc website. Also, the question from audience will be accepted at the time of question and discussion and the latter half of this webinar. And also, we can use a polling system. It will be activated a few times during the webinar. So your reaction is highly appreciated. And before the battle, I would like to talk about some kinds of overview. And then the first polling, no, not yet. Let me show the agenda. So then the polling of the audience, and after that, we have a lecture, two lectures from the Professor Rakudawara and the Professor Seki. And also after that, we have a rebuttal. And also that we can accept the question, the comments from audience. And then we have a discussion time. So I'd like to talk about the overview of the Sleep Plus. So some of our colleagues here doesn't know much about the Sleep Plus, but this term, Sleep Plus, was invented by Shikewan here, and he started to use this term. This is very useful and easy to understand. The Sleep Plus some kind of procedures. And the first procedure was done by our group and the Sleep Plus DJB. It was first to avoid gastric cancer or bypass stomach after rheumatoid gastric bypass. And that was just a modification of BPDDS to avoid malnutrition for aging. Next, please. Next, please. So the 3+ is a sleep gastrectomy plus some kind of bypass and also some kind of anti-reflex procedures. Next, please. The 3+ contains this kind of some amount of some kind of bypass procedures and also the anti-reflex procedures. So I'd like to go to the first poll. So have you ever known the term 3+? Please click yes or no. I know some of the Asian surgeons know about 3+, but the other region don't know much about 3+ term. So that let me check the term. How much of the people know the term of 3+? So we have a few minutes, a few seconds to go. Yeah. So I'd like to talk about the result. 58% of the people here know the term of 3+. That's great, CK. It's you invented this term. Yeah.
Okay.
And
Nice.
yeah, that's nice. And also I'd like to know, yeah, this is a result. That's good. It's more than we thought, more than I thought. So let me go to the second one. The second question is that do you think low MI gastric bypass is better than 3+ for your Asian patients? So low gastric bypass is a classic and one of the most popular bariatric procedures. And then the 3+ is a new concept. So I'm waiting for the polling. Oh, that's good. Oh, that's really nice. Wow, it's almost 60% said yes. Thank you, guys. So so I'd like to go to the debate. The first speaker is Dr. Lakdawar. So please start your presentation, Mufi.
So hello everybody, and as you can see that is that 1 second. Yes. Can you see my screen, please?
Yes, we can see.
Yes. All right. So as you could see, so the Roux-en-Y gastric bypass is where I'm supposed to speak today. We all know how the Roux-en-Y gastric bypass is done, and there are different variations. The banded variation is one of them, and nowadays the new added variation of increasing the biliopancreatic limb becomes. So this is not something new. This is a very, very old procedure, and it was one of the only procedures, the first procedures, which we thought was supposed to be the game changer in terms of treatment for type 2 diabetes, at least in the adult population. We also do know that there are lots of level 1A evidence to prove that a gastric bypass surgery is better than intensive lifestyle, as well as medical, in this paper, Crossroads trial from David Cummings. As you can see, the HbA1c, fasting glucose levels, and various other parameters for type 2 diabetes, as by the American Diabetes Association, all gastric bypass, which ideally is supposed to be technically the gold standard procedure, has got better results. Then this paper, which includes some of the Asian data from AJ Lee's group, from Saeed Ikramuddin, again in terms of management of type 2 diabetes, hypertension, and hyperlipidemia. Again, a Roux-en-Y gastric bypass is way ahead of the competition in terms of intensive lifestyle, and even at 5-year and 2-year outcomes, as you can see out over here. Now, this is paper from CK, who's a part of this panel today. And even his case, the Roux-en-Y gastric bypass, even in a lower BMI, between 25 to 35, has shown very, very good results. So my take with this meta-analysis, which also shows that the Roux-en-Y gastric bypass across all these authors, and a lot of them are Asians, shows that the Roux-en-Y gastric bypass is a time-tested, proven method to treat not only short-term outcomes with the Roux-en-Y gastric bypass, but even like in this case, 5-year results from Brazil, from Ricardo Cohen's group, saying that even at 5 years in the low BMI group, we've got more than 88% remission. This is from our group from India. Again, in the low BMI, we are seeing that at least 73.1% and more than a 95% total improvement in gastric bypass, even in the low BMI group. And the reason why I talk about low BMI is because that is where Asia stands today in terms of type 2 diabetes. Now, in terms of weight loss, we also do know that even at 10 years follow-up, a Roux-en-Y gastric bypass, give and take a little bit here and there, will always maintain its weight loss, irrespective of whatever we compared to all the other procedures. But today, sleeve gastrectomy becomes the #1 worldwide procedure, and the Roux-en-Y gastric bypass is falling. So what about the sleeve gastrectomy is so attractive? Well, sleeve gastrectomy, as you know, is a great procedure in a high-risk patient, a super obese patient, patients with complex abdominal wall hernias, small bowel resections, Crohn's disease, inflammatory bowel disease, transplant recipients and candidates, patients give and take a little bit of psychiatric history, those with active smokers, NSAID users, and the only place where probably it's a contraindication today remains a severe GERD or a bad esophagus, but that's also debatable for those people who believe only in the sleeve gastrectomy. What about type 2 diabetes mellitus? Well, hitherto, all the data that we had proved that a Roux-en-Y gastric bypass was better. But after this score, we do know that probably it's only in the mild and moderate with this Cleveland score that the Roux-en-Y gastric bypass is better. With the severe patients with type 2 diabetes, both have equally good results. So when we compare the sleeve with the Roux-en-Y gastric bypass, we do know that this paper, the Stampede trial at 1 year, at 3 years, as well as at 5 years, have all shown that the Roux-en-Y gastric bypass works far better than the sleeve gastrectomy alone, at least. So we need to do a little bit more with the sleeve, at least in the more complex, more moderate patients with sleeve. Now, what about the sleeve plus randomized clinical trial? Well, we do know with this study that probably maybe the sleeve gastrectomy and the Roux-en-Y gastric bypass more or less does the same. And this paper, again, the SM-BOSS trial, again, if you see the sleeve gastrectomy and the Roux-en-Y gastric bypass have got almost similar results. It's only in the sleeve that those with diabetes have worsened rather than getting better, though Roux-en-Y gastric bypass is better. This paper compares the OAGB Roux-en-Y gastric bypass and the sleeve, where again, it has been shown that maybe the Roux-en-Y gastric bypass and the OAGB is slightly better than the sleeve. So Ali Aminan and his group compared all these various level 1A evidence, the Stampede, the sleeve pass, and the SM-BOSS trials. And what they noticed is that give and take a little bit of 5% difference, but the sleeve kind of was almost similar. But we also do know that the sleeve gastrectomy has its own Achilles heel. One is weight regain, and the other one is GERD. And that's no debate about that. Okay, long-term year results show that the mean weight loss, other than Rawlings study, most of the time we accept a 50 to 55% total body excess body weight loss at 5 years and beyond. As you can see out over here, that at 8 years, with very few numbers, we still do know that the sleeve gastrectomy does regain weight. There are lots of ways of calculating how sleeve gastrectomy does put on weight, and various studies have mentioned various things. So we don't have one parameter which says how a sleeve gastrectomy should be clarified when they do regain weight. Therefore, we need sleeve plus procedures. We need an add-on procedure. Sleeve gastrectomy alone, we do know over a period of time might not be the answer for the super obese, might not be the answer for diabetic patients, irrespective of all the things that I told you before, where a sleeve is an indicated case. Therefore, we've got the SARDI-S and the duodenal switch. Now, both of them, the sleeve is done as a first stage and the SARDI-S is done, because if you do the SARDI-S or a DS along at the first stage, then we do know that the morbidity and mortality figures are much higher. We've also played around with the ileal transposition, both diverted as well as non-diverted. And then we've got various options of the sleeve bipartition. You can either do it this way, which is Santoro's way, or you can do it loop like Wilfred Mui and his colleagues have done in Hong Kong. I leave the results to Seki to speak on these procedures. But we do know that when you do regain weight with the sleeve, and these are some of our own data, we do know that if you add on a plus procedure to the sleeve, you do get additional weight loss. You also get very good remission rates with diabetes, hypertension, sleep apnea, dyslipidemia. So when you add on another procedure along with a sleeve at a second term, you do get very good results, as you can see in this data, unpublished data from our side. Now, what if we compare the duodenal switch or the biliopancreatic diversion, which are ideally supposed to be the best procedure for weight loss as well as for diabetes remission? Well, this paper tells us something otherwise. If you go to see that GRD is the only quality of life questionnaire which increases with the duodenal switch as compared to the other things. And the percentage weight loss actually at long term, at almost 80 months, is not that different. It's maybe 4 or 5 BMI points, total body weight loss points different. So it's not too different in the long term. And therefore, we get the low BMI, and that's why we talk about Asia. So we've got, like Kazoo said right now, we've got Kazoo's variation of the Roux-en-Y sleeve DJB, which Seki will speak about. We've got Dr. Wang's modification of the loop Roux-en-Y DJB, but we've also got the PJB, or the proximal jejunal bypass, which is emerging, and some endoscopic options of doing it have also emerged. We do know that Professor Alamau from Chile has also spoken about the proximal jejunal bypass, and very good results, where they don't believe that duodenal exclusion is important, but rather just the proximal jejunum needs to be excluded from the food, and therefore they don't believe in the foregut theory of hypothesis. There are 2 human studies so far which started this whole thing. One was from John Melissa's group, as well as from the Chinese group, as you can see here. And both are very, very early studies that show that maybe the PJP has got a role to play. However, there's no long-term data to prove. When we compare the Roux-en-Y gastric bypass with the sleeve plus procedure, this is again papers from Korea, okay, from Dr. Kim's group. And what he believes is that the DJB is not an effective method of controlling type 2 diabetes. Probably it's in the most severe form than what Seki will show later on. And a Roux-en-Y gastric bypass is maybe a better option. This is what they've said. This is probably in Raj's group, where he's actually said that the sleeve DJB does work, but however, there's no long-term follow-up in his paper. This is the number of sleeve DJBs we've done in our group. And I've just put a snapshot of what we've done. Unfortunately, if you see, what we do see is only 12 out of the 28 had no remission of diabetes. In fact, the diabetes did not go away despite the proximal bypass. 6 out of 20 had remission. So more number of people didn't have remission, because probably we're doing it in the more complex diabetics in this group, because we believe that bypassing 200 centimeters of the biliopancreatic limb probably would give us better remission. That's why we did the sleeve DJB in this group. But however, 11 out of these 28 patients had persistent reflux. And that is something that we need to know, which will happen with the sleeve, irrespective of the pylorus being intact. So the problems with the sleeve persist. In addition, we are adding problems of a sleeve plus, which is malabsorption. So we should not ignore the elephant in the room when we talk about the sleeve plus procedures. We do know that, quite like the OAGB, and we all talk about bile reflux, the sleeve DJB or the SARDI-S will also have its own set of bile reflux, which is mixed acid and bile reflux. as well as the supplementation. This is the way we supplement all our patients. So we do increase the supplementation even in the sleep DJB just to match up with the amount of supplementation that these patients need. This after supplementation also, you can see that the iron levels remain low in a sleep plus procedure, which does not necessarily happen with the Roux-en-Y gastric bypass procedure. And then we have quality of life questions. In some patients, we have constipation in the sleep DJB. In the others, we have loose stools. We have bloating and heartburn, which actually never really happens with the Roux-en-Y gastric bypass procedure. So to conclude, I would like to say that the duodenal anastomosis is more difficult for any given surgeon. Even skilled surgeons will tell you that a gastric anastomosis is far, far more easy than a duodenal anastomosis. There is always going to be a mixed reflux in reality of a loop anastomosis whenever you take in the long-term sequelae of esophageal cancers, especially in the Asian scenario. Why would you not want to just do a Roux-en-Y, which gives you almost similar results? Anastomotic leak, if it will lead to biliary peritonitis and an emergency, which might not happen with a Roux-en-Y gastric bypass. Sleepless procedures with proximal bypass, whatever data today we have, are not better than the Roux-en-Y gastric bypass for diabetes. And we don't have long-term data. So maybe longer term, like we've seen in our data, a lot of people do regain weight with the sleep DJB, and you might actually see not a very good result with diabetes. Sleepless procedures with the distal bypass are definitely superior to the Roux-en-Y gastric bypass, but carry quality of life questions as well as nutritional sequelae. And maybe the new Roux-en-Y gastric bypass with a longer limb, biliopancreatic limb, almost comes close to some of the results with the SADS or the BPDDS if you bypass more than 150 to 200 centimeters of the biliopancreatic limb. But I do agree that in countries of East Asian origin where cancer is very, very prevalent, like Korea, Japan, and some parts of China, that a sleeve bypass will still remain a better option. So I would like to say that let's not reinvent the wheel. In a majority of our patients of Asia, even other than East Asia, we do know that a Roux-en-Y gastric bypass works irrespective of whether they're high BMI, low BMI. So let's not reinvent the wheel, because let's not try and be the first guy to do a procedure, because just like this cartoon says, he shouted about something new invention, and that's what hit him. Thank you so much.
Thank you, Murphy. That was a great presentation. I'm almost convinced by your presentation, but Dr. Seki will try to convince you by his presentation regarding 3+. So, Professor Seki,
Yes,
please start your
yes.
presentation.
Okay, I tried to do my best. You see my slide?
Yes.
Okay. Okay, so it's my role is on Sleep Plus. And first of all, I don't include it's a purely restricted procedure like a duodenal switch or the SADI and as a Sleep Plus procedure, because I believe this kind of procedures is not ideal for the Asian patient. It's too aggressive. So this is So this is a trend in the percentage of bariatric metabolic surgery worldwide. As you know, the trend in bariatric procedure is very dynamic. We are still looking for the ideal procedure. And then right now, as Mufi said, the sleep is the #1 procedure in the world, accepted procedure in the world. So what is good and bad in gastric bypass? And the good thing is, as you know, the very strong procedure for the GERD, and the strong procedure for diabetes as well. And the bad thing might be the marginal ulcer and dumping syndrome, both of which deteriorates the patient's quality of life significantly, and the gastric cancer things. So it's an incidence of gastric cancer is comparatively high in East Asian countries such as in Korea, Japan, China. And if you look at the literature, you can find it's a handful of the gastric cancer in the remnant stomach after gastric bypass or even a mini gastric bypass. So we cannot ignore. Actually, we do have a couple of experience of the retrograde double balloon endoscopy to look into the bypass stomach for the screening purpose. But quite honestly, it's just a pain. It's not ideal. It's not good for the screening purpose. So recently, we experienced a very impressive case. This is a 60-year-old lady coming to us seeking for diabetes treatment, and we did a sleep DJB for this patient, for this specific patient, and after 1 year after sleep DJB, at the time of the routine endoscopy, we detected an early gastric cancer lesion at the distal tube. And the pathology was successfully treated by endoscopic submucosal dissection technique. So it's if we offer the Roux-en-Y gastric bypass for this specific patient, it would be very difficult to detect this pathology at an early stages. So this is the sleep DJB, and our favorite procedure, sleep plus procedure. It's a no remnant stomach, and the DJB effect and ghrelin effect and less dumping and less also because we preserve the physiological valve pyloric ring. So this is comparison in terms of the prevalence of the dumping syndrome between the sleep gastrectomy and the Roux-en-Y gastric bypass. As you know, it's the prevalence of the dumping syndrome is statistically significantly higher in the gastric bypass group. And this is a very, very interesting study using the wireless Bravo system. It's a pH monitor. The study group put on two Bravo system, proximal and distal to the pylorus after the duodenal switch surgery, one of the pylorus preserving surgery. And they show the percentage of time with pH under 4 was 70 pre-pylorus and 13 post-pylorically. So their conclusion that duodenal bulb had a large buffering effect, counteracting the large amount of gastric acid passing into the small bowel. This physiologic effect could explain the low incidence of stomach ulcers. And the glucose variability is the study group using the continuous glucose monitoring, and they show the stomach pylorus preserving surgery, DS, demonstrated a less pronounced postprandial glucose variability compared to the gastric bypass. The implication of the glucose variability in bariatric surgery is unclear, but then from the viewpoint of the endocrinology, the postprandial variability potentially leads to the diabetes complication. So it's not good. So what's good and what's bad in sleep gastrectomy? The bad point in the sleep gastrectomy is in the GERD, and probably the less effective for advanced diabetes and long-term weight loss durability. So this is a randomized control trial published by Praveen, comparing the Roux-en-Y gastric bypass and sleep DJB. It's already mentioned by Mufi, and they show exactly the same effect between in terms of the weight loss and diabetes remission between the two procedures. And this is our own case series for advanced diabetes patients. It's an anti-diabetic effect is very good, almost comparable or even better than in the gastric bypass. And its effect is pretty durable, at least in up to 5 years. So this is another sleep plus procedure. It's a sleep with transit bipartition. You can see the two lumen. One is the pylorus, and the other is an gastroileal anastomosis. And you can see the pretty durable weight loss effect up to 5 years, and diabetes is improved without duodenal exclusion. And this is another sleep plus procedure, sleep gastrectomy with jejunal bypass. It's a comparative study between the Roux-en-Y bypass and this procedure. up to 3 years. Diabetes remission similar, weight loss similar, and complications similar. But in hemoglobin and calcium was lower in the gastric bypass group. So this is the another sleep plus procedure, the loop DJB, proposed by the CK Hwan, one of the panelists today. He compared the Roux-en-Y gastric bypass and loop DJB case matched. So it's their result is an operation time is a little bit longer in the sleep DJB group, but the weight loss similar and the resolution comorbidities is quite similar between the two groups. This is almost the same procedure done by Professor Wei-J Lee, Taiwan. It's a loop DJB. Their conclusion is an operation time is a little bit longer in the loop DJB group, but weight loss is better than a gastric bypass, and the resolution comorbidity is better than gastric bypass without difference in nutritional status. And they recently published a 5-year result of the sleep loop DJB, and they show the durable loop DJB is a durable primarily bariatric procedure with sustained weight loss and a high resolution of diabetes at 5 years. But again, the de novo GERD is the major side effect. So it's in the latter half of my presentation, I talk a little bit about the sleep gastrectomy plus an anti-reflux procedure. Of course, the gold standard is converting to the gastric bypass, but the other alternatives is radiofrequency ablation, the Stretta procedure, and the LINX prosthesis, and sleep plus fan application, and ligamentum teres cardiopexy, and electrical stimulation. So it's a new concept is coming year by year and validated. And some of them is very promising. It's in a LINX. As you know, it's a magnetic sphincter augmentation system, FDA approved, and the long-term efficacy and safety is already shown for the primarily GERD surgery. And their result of the placing the LINX after sleep gastrectomy is very good. All patients greatly improved GERD after 2 to 4 weeks, and all had a lower DMS, the Mester score, with a significant decrease in the frequency and severity of their symptoms. And this is the sleep plus ligamentum teres cardiopexy proposed by CK Hwan, and he recently published their initial early experience, and based on their data, and the result is pretty good. The follow-up led up to 6 months. The symptomatic GERD requiring PPI was decreased significantly. So it's ladies and gentlemen, in summary, currently the sleep is the most widely accepted bariatric metabolic procedure worldwide, especially in the AP region. And the gastric cancer is more prevalent in the AP. Major drawbacks of the sleep and de novo GERD and durability of the diabetes control. However, the various new procedures complement to sleep, that is sleep plus, have been invented and validated. Some are very promising despite the paucity of long-term data. So in conclusion, in my opinion, sleep plus is superior to gastric bypass and probably the more important, especially in the AP, although there are definite needs for additional evaluation under proper framework to ensure. Thank you very much.
Thank you, Yosuke.
Thank you.
I'm also almost convinced by your presentation, and I'd like to ask Mufasa to counter him.
So Seki, a great presentation. I had only a few points to raise from your presentation. You admitted that GERD remains a problem. Now with the Sleep Plus, you do understand that there is a mixed reflux, right? So you are going to get bile up in the esophagus. In countries which have high prevalence of gastric and esophageal cancer, do you think it is worthwhile considering this? Because the time duration to pick up a cancer might be anywhere close to 15 years and beyond. So are we doing a bit too much right now to begin with? The next thing I wanted to ask you is that rather than doing complex procedures like the Sphinx and putting ligamentum teres around it, why not just do a Roux-en-Y gastric bypass, which you self-admittedly said is a better anti-reflux procedure? Now, if there is a concern with gastric cancer, what I would say is why not add a remnant gastrectomy, which is a much simpler procedure to do rather than doing, if you're removing 2/3 of the stomach, why not remove maybe a little bit more and do a remnant gastrectomy if cancer of the stomach is that much of a concern? Because then you've removed the entire stomach, so there's not going to be anything. We do also know from all the data that you've shown is that long-term durability of diabetes remission is always going to be a question, despite the great results that you and your team with Kazoo showed at 5 years. So my question is, let's not complicate matters. Let's keep things very simple, because it's simple things are easier done by majority of us who are not as gifted as you and Seki and CK, who are sitting on this panel. So me and Ken and the rest of us, I think a Roux-en-Y gastric bypass is a much better procedure. Thank you so much.
Right. So it's I think the time is limited. So it's I answer very simply, quickly. It's okay. So number one, it's and so the resection of the remnant stomach. It's we actually did handful of the resectional gastric bypass in our experience, but it's not easy. And not easy means you know, it's we need to extend the wound. It's wound complications and bleeding complications, and the so I think it's resectional gastric bypass is not a good choice. This is one thing, and it's a mixed reflux. It's one of the point I want to emphasize is the preserving the pylorus. Yeah, so it's not the same the mini gastric bypass. Of course, after the mini gastric bypass, the bireflux could be a very serious problem. The 10 years and 15 years from now, the gastric cancer caused by the bireflux could be a problem. But it's in a pylorus preserving procedure like in a sleep DJB and even a loop DJB. In my experience, there is a very small incidence, small chance that I found the bireflux inside the gastric tube. This is my opinion. And it's what is the other one? The simple procedure. It's in our medical community, it's still it's an possibility of the gastric cancer in the remnant stomach is a higher priority. So I answer your questions.
I think we kind of.
Okay. Mufi talked about esophageal cancer after 3 and 3+ procedures. How do you think about this?
Yeah, it could be a very serious problem than in the next 5 years and 10 years, and because we found more and more adenocarcinoma at the EG junction after sleep gastrectomy case reports. So it's it could be a very serious problem. So it's we need to validate, and it's we have a couple of options like CKs and ligamentum teres cardiopexy and links and so it's we are waiting a more rigid data. That could be a very serious problem.
Okay, thank you, Yosuke. So the next we'd like to have a question from audience. So the audience here, please write your question to the question. Positions. And during that time, so we'd like to ask my panelists regarding the question that the Mufasa raised. Actually, the esophageal cancer, the Barrett esophageal cancer, could be a problem after sleep gastrectomy and sleep plus procedures. And I know that Professor Che is one of the expert of the esophageal and the gastric cancer in our region. So how do you think about Barrett esophageal cancer in Asia? Do you think it's not so common compared to Western countries? So what's your opinion?
I think it depends on area. Korea and Japan, esophageal cancer is relatively rare, and even though patients who have a reflux, they don't have a high instance of esophageal cancer. But in China, I think the situation is a little bit different. The esophageal cancer incidence is relatively high, so maybe in Korea and Japan, Sleepy Plus is maybe a good option. But in China, it's my personal opinion. In China, maybe they should be checked every year after Sleep Plus, or they should avoid another. They should find another procedure. That's my opinion.
Oh, that's great. So I didn't know so much the esophageal cancer in China. So is that cancer? Esophageal cancer in China is also adenocarcinoma, like you know the Barrett esophageal cancer.
How do you think, Dr. Huang?
Yeah, Shike knows much about China.
Can't
Shike,
hear
can
you,
you hear
CK.
me? We cannot hear you, Shike.
Maybe
CK.
it's a mute.
We can hear.
You have to unmute the phone, CK. There's a microphone button.
Ken, what can you say to that, Dan?
No, we can
Ken,
hear.
Ken, what's your opinion?
Again,
Ah,
Can you hear
can
me?
hear you now.
Okay, good.
can you hear me?
Yep.
Yes.
Okay.
Oh yes. Oh, okay.
About esophageal cancer in Taiwan is also quite rare, but it's a little increasing. I think it's related to some alcohol drinking now. And in south part of China, there's some province, they are very highly prevalent in esophageal cancer. In fact, I agree that sleep gastrectomy can cause reflux problems, yes. And so I think it's a more high prevalent surgery now in the world. I think that as a surgeon, we need to find out the reasons and try to solve the problems. In our data showing most severe reflux after sleep gastrectomy, most is 75% comes from the intrathoracic migration of the sleep tube. So now we need to fix the tube after finishing the sleep gastrectomy. So I think that will be decrease a lot of instance of a de novo reflux. The second is, I think esophageal cancer not related to reflux only. I think gene and food and also the bioreflux are all the potential risk for the developing the esophageal cancer. So you see that in Western country, they are much more high prevalent compared with Asian groups. So I think right now, we cannot conclude that esophageal cancer could be really increase a lot in Asian group if the patient develops severe reflux. In my quite thousands of cases of sleeve gastrectomy, we did not have any case develop Barrett's esophagitis after sleeve gastrectomy, even 5 years more data showing that. So I think sleep plus, yes, it might have the issue of the reflux, but if you treat it concomitantly during the first operation, maybe fix the tube, use ligamentum tears, or do some preventive manner, that maybe someone would invent new methods. I think that will solve the problem. Okay.
I just want to make a comment. I do actually you know, I mean, in my cohort, I actually have 2 patients after gastric bypass actually develop esophageal cancer. So you would think that gastric bypass actually will be having a lower risk of developing esophageal cancer. I think it's kind of, it is related, but it's not dependent. The comment about cancers, I guess, coming from the Australians' perspective, the fact we are sitting here discussing this is because we still haven't got the perfect procedure. You know, you all know the history of lap band in Australia, that is originated in here and it comes and it goes. So at the moment, we seeing the procedure that is so far the most durable is still gastric bypass. Sleeve is durable enough, but we start to see some failure, and therefore we're having them talk about this plus, you know, thing. So the problem about the plus is, are we plussing for treating complications or preventing complications, or are we plussing because we want to treat, we want to add additional metabolic effects? So you got to differentiate between both. And all this variation of bypass, I think, you know, we got to be careful, because I think we're here talking to a lot of the younger guys that are starting the procedure. They might be competent surgeon, but I think if it's not done right, there's catastrophic consequences.
Okay, thank
And
you. We got
I
some
have some.
question. Mr. Choi?
another question to Dr. Seki.
Yes.
Some patients who received the Ruang-I gastric bypass suffered from severe postprandial hypoglycemia.
Mm-hmm.
In Korea, we also have a experience of severe postprandial hypoglycemia after Ruang-I gastric bypass, especially for patients who like to eat some carbohydrate and sweet fruit. Then they suffered from severe postprandial hypoglycemia, maybe shock, and go to an emergency room. So I think it's one of a major problem in Asia. And sleep itself also shows the hypoglycemia too. So I want to ask you a question. The sleep plus may be a higher instance of hypoglycemia compared to sleep itself. So what is your opinion about that?
Yes, thank you. It's a very good question. And based on my experience of the sleep DJB, Roux-en-Y DJB, the symptomatic dumping syndrome, the incidence is quite low compared to the gastric bypass. And it's in my impression, there is no big difference between the sleep alone and the sleep DJB. So it's I think the preserving the pylorus is very useful to reduce the incidence of the postprandial glucose variability. So it's an advantage of the sleep plus procedure, preserving the pylorus.
Thank you.
But still not. But yet not zero. Not zero. Yeah.
Can
but
I
much
comment
better,
in this?
Yeah.
Yep.
Can I give a little comment? Because I think the postprandial hypoglycemia, we find 3 cases in our previous Roux-en-Y gastric bypass series. These 3 cases, they present with severe dumping syndromes, and the sugar dropped to less than 60 after you do the OGTT test. So we decide to convert the case back to the sleep or sleep plus procedure, or the dumping syndrome and postprandial hypoglycemia disappear. We publish in the papers. But in sleep procedure or sleep plus procedure, till now, even the case series is much more than the Roux-en-Y, but we did not see any cases have this kind of problems. So I think that the pylorus preserving is still very important to prevent the dumping, especially for severe dumping. I agree with Yoseki that dumping still can happen in sleep, but most of the symptoms very mild, and it can be corrected by your food change. But in severe dumping syndromes in Roux-en-Y, especially in late dumping, cause hypoglycemia one. In some cases, you will see it's very severe. The patient even get fainting on the road. So I think it's an issue for those who consuming more carbohydrate country like Asia.
Can I ask a question to Dr. Lakdawala? In Asian who are not tall and obese, diabetes, then sometimes they have very short mesentery and very thick mesocolon. So it is not really impossible to make anticolic gastrojejunostomy. So we should make a retrocolic gastrojejunostomy in that case. But in that case, also make a hole through the mesocolon is very difficult and dangerous. So I think in that case, sleeve plus is technically easier. So what is your opinion about that?
So, Professor Choi, that's a good question. We've not really technically found it a problem once you've split the omentum in the midline. We've done higher BMIs like 70, 70 plus, and we've not really faced a problem. However, what you're saying is if doing a gastric bypass is going to be a challenge, then it will be also a challenge to dissect the duodenum in such a heavy patient. So I would rather say then just do a sleeve rather than doing a sleeve plus at the same time, because both are two different aspects. If your technical challenge is there, then I think safety is the most important concern. However, going back to the last discussion that CK and Seki had, I want to ask both of you, if we do scopies in normal patients, irrespective of before bariatric surgery, because we do all our patients pre-op scopy, how many of these patients have bile already in the stomach? And what is the relevance of the pylorus then? Because if there's bile before a surgery, how many of those cases do you think that post sleeve plus procedure, they will not have bile in the stomach?
CK.
Okay, this is a good questions. In fact, we routinely do pendoscope by our gastroenterologist. So if during the pendoscope we find there's bile in the stomach, I think it's a relative contraindication to Roux-en-Y gastric bypass, but not the contraindication to sleep plus. Because when you have bile regurgitation to your stomach, when you exclude the stomach, you don't know what happened after 10 years, 20 years later. The intestinal metaplasia can happen and you cannot screen it. So when the patient have bile reflux pre-op, I think that would better do sleep procedures, but not the Roux-en-Y. But I don't have the percentage, but in our series, in my own observation is quite low in Taiwan cases. I think maybe less than 1% that pre-op there's bile reflux in the stomach.
And yes, and I also then do not have an exact data. It's how percentage of the patient found by reflux, but it's this is a debate between the Roux-en-Y gastric bypass and sleep plus, but it's among the various types of the sleep plus procedure, it's the reason we prefer the Roux-en-Y sleep DJB is because of the bireflux, because it's after Roux-en-Y bypass we don't find the bireflux into the sleep. So.
I have a question for Mufi. Okay, because this is a debate of comparing Roux-en-Y and sleep plus. But I think that in your hand, you still do sleep plus procedure, right? So what's your indication for that? And what's your contraindication for Roux-en-Y gastric bypass?
So my contraindication for Roux-en-Y gastric bypass would definitely be like the list that I put up. Any patient with inflammatory bowel disease, any patient with a cirrhotic Child's B plus and C and various other things. A patient with bad kidney disease where the creatinine is above 4.5, so grade 2, grade 3. So those would be clear-cut contraindications for a gastric bypass. Someone who's a smoker and who's not going to give up smoking, I think the risk of marginal ulcer would be much, much higher. So for me, the classical indication for a sleeve DJB would be someone who wants, who's a smoker but still, irrespective of that, and we know that sleeve alone will not work for them. So maybe a sleeve DJB would be a good enough option. Like I showed you, we did 30 cases. We didn't really get very good results, at least in the complex diabetics. We thought bypassing 200 centimeters of your biliopancreatic limb would give us the results. We were a little disappointed. We did not get the same results as we hoped we would get. But that's what our take is. So sleeve DJB is very, very few patients now we do them on, because Roux-en-Y gastric bypass is our standard time-tested proven procedure. We've started increasing the biliopancreatic limb. Maybe 2 years later, I might be able to give you better data. Now our standard limb, biliopancreatic limb size is around 150 and 200 centimeters for a Roux-en-Y gastric bypass.
Yeah, this is very important issue about length of BP limb and other limbs after bypass or DGB procedures. But I need to tell that there are some questions from audience. One is talking about gastric cancer in the remnant stomach. So what do you think about the gastric cancer in the remnant stomach from a viewpoint of the gastric cancer surgeon, Professor Che?
Still, in Korea, we also have many debate because the patient who do not have a high risk factor, no high H. pylori infection, and no pre-cancerous lesion, no family history, then the remnant stomach is prevented from the carcinogen. So maybe the gastric cancer is not high, very rare in the case. This is one hypothesis who favor the gastric bypass. But still, the incidence of gastric cancer in Korea, Japan, also in China is high. So we should be cautious too about that. So personally, if I have a patient who want a Roux-en-Y gastric bypass, I checked many things. No H. pylori infection, no precancerous lesion, and no family history. And also, I explained a lot to remnant gastric cancer. So, but still in Korea, it is just cautious.
Can I ask a question? Because in that case, in the country, if you have patients that is high risk, why can't you also spend a little bit more time and resect the stomach at the same time of the bypass? It might sound radical, but it's probably the way that you can kind of minimize the potential future risk.
Okay. Sometimes, personally, I perform the resectional gastric bypass too. But I have a patient who have a severe hypoglycemia after Roux-en-Y gastric bypass. Then I stop the resectional gastric bypass because any patient who have a very severe hypoglycemia, then maybe I need some revisional surgery too. That's my opinion.
Good. Thank you, Professor Che. And also we have some questions regarding how often do we need to screening for endoscopy after surgery? So Roux-en-Y and the 3+. What do you think?
Every year.
Okay.
Every year for me. Yes.
How about you, Ken? Ken?
Symptomatic. Only if they are symptomatic. I think in Australia, the incidents are not as high as Asian. So I guess unless the patient ethnicity is Asians or family history, we usually only screen if patients are symptomatic.
Mm-hmm. How about you, Yosuke?
And we don't do right now, but it's I recommend that's an yearly endoscope, especially for the sleep patient.
How about you, Wufi?
I think it is mandatory that irrespective of the symptoms or not, you should be doing a yearly endoscopy after all bariatric procedures, because some of the unpublished data, and we should be publishing it very soon, it is part of we've seen the number of marginal ulcers with the Roux-en-Y gastric bypass have increased dramatically just because it's asymptomatic patients we are scoping. the amount of reflux esophagitis has also gone up very, very high in those patients who are asymptomatic post-sleeve gastrectomy. So I think it is mandatory that we do endoscopies in all our pediatric patients, if cost is not really the concern, or you figure out a way of featuring it into their cost.
Okay, thank you. So how about you, Professor Che?
Yeah, just I don't have data, but after 40 years old, I recommend every year checked. But before that, 2 or 3 were mandatory, so if they have a symptom.
Okay, thank you. So that I need the many things to discuss more, but time is very limited. So we want to go to the last poll. So do you think a 3+ is better than 3 alone for Asian diabetes patient? So some kind of Asian patient, diabetes patient, need not only sleep, but also need a sleep plus procedure. Or sleep alone is enough for Asian patient? Good. Please show us the result. Yes, so the many of you think the 3+ procedure is better than 3 alone for Asian diabetes patient. So the last question to audience is, so do you think Luema gastric bypass is better than 3+ for Asian patient? It's the same question at the first, the poll, I mean the before discussion. So please vote. Okay, let me show the result. Wow, it changed. The first time, the yes was 58%. Now, no, which means the 3+ is better, is 56%. So that both Mufi and Yosuke did a great job. And the Yosuke can convince a few participants, and that's a great deal. Thank you. So it's a time limited, so that I'd like to conclude this webinar. So can we see the panel's face? Manuela. Manuela, can you show us the face of panelist? No. Okay. Anyway, that we need to see the discussion. We are not closed yet, so that we will have the more discussion at the Ifso Madrid at the Ifso Apc session. So if you are very interested to join this kind of discussion, please come to Ifso Madrid and join our session of the Ifso Apc. Is there any comment from the panelists? Is it okay?
I just want to make a brief comment. I'm in Greece, so I just visited the place of original of medicine called Hippocrates, and remember the oath is do no harm. So I think besides understanding the potential and the power of treating all the disease, we got to make sure that we don't cause any complications. So we need to actually encourage the surgeon, if they want to do the procedure, report the side effect, report the complication, so the people can decide based on their experience and their technical experience and the country and the culture and what they eat to decide which procedure is best for them.
That's a good comment. Anyone Adi? Okay, so thank you everyone. Well, thank you speakers, the panelists, and the audience here. So it was a very nice webinar from Ifso Apc. So I'd like to see all of you in Madrid in September. Thank you.
Kazu?
Have a good day. Have a good night.